Hi, Dr. Flores.
Hi, how are you? Nice to see you, Maryangela. Always a pleasure
Nice
to be with
to
you.
see you. Nice to see you too. And thank you for being with us today. For those who don't know Dr. Flores, well, he's been with our organization since, again, the inception of our organization. He's just been with us for the whole time. He is currently is the director and chair of the Ambulatory Community Services, Associate Physician, Motility, and Gastrointestinal Disorders, both at Children's Hospital, and that's in Boston, Massachusetts. So thank you, Dr. Flores. It's all yours.
Well, I think initially what I thought we'd do is make it this interactive and talk about a little bit about the pediatric gastroparesis. That is a reality or a myth. You know, a lot of people has questions sometimes the diagnosis. The definition of gastroparesis is what we call is a gastric paralysis. It's a clinical syndrome that is characterized by impaired transit of liquids or solids from the stomach into the duodenum in the absence of any type of mechanical obstruction. And I would say that it's probably the most common gastric motility disorder. And it's important to understand the pathophysiology of this condition, because the rate of the emptying of the stomach, you know, is important for the digestion of nutrients, obviously, but also for the process of glycemia in patients who have diabetes or disorders of the sugar metabolism. And the other thing is that affects the pharmacokinetics and the way that drugs get absorbed. So I think it's important to distinguish that. The other thing that is a little tricky these days, when you talk about the classification of the gastrointestinal functional disorders or disorders of the brain-gut axis, like is now known, is the issue of how different is this from non-ulcer functional dyspepsia. And there is a lot of overlap. And a lot of the symptoms that these patients present might change a little bit. And I think one of my jobs now is to try to define better and see if we can make the differentiation between pediatric patients and adult patients. And I think in adults, the most common symptom probably presentation is nausea, and then vomiting, bloating, early satiety, weight loss, epigastric pain, discomfort, especially postprandial after eating. And then the other issue is the formation of gastric bezoars. What is basically when the food doesn't empty the stomach, it can accumulate fiber and form these masses of food. And sometimes they can be, patients with psychiatric problems, they can swallow hair or type of foods of that nature. In the pediatric population, that obviously the older you get, the more you start looking like an adult. But in children, usually can be presented with food refusal, irritability, failure to thrive. Abdominal distension is not unusual to present like that. Feeding intolerance, there are patients, babies that are not able to tolerate food by bottle, and they require interventions. Presence of gastroesophageal reflux, another one. I always try to tell people that if you think about the stomach being a balloon, and the balloon has a neck, the neck of the balloon is very long. The moment you start inflating the balloon, the neck decreases size, and eventually the balloon blows and explodes. That doesn't happen in the stomach. What happens in the stomach is the little valve between the esophagus and the stomach, called the lower esophageal sphincter, is not able to sustain the pressure, and then you get backwash type of fluids or food into the esophagus. Abdominal pain is not uncommon. If you don't have emptying of the stomach, the mechanism that controls satiety and the hormones that control this mechanism are sort of not in rhythm, and that produces anorexia. So there are patients that they have anorexia, different than the fact of anorexia nervosa, for instance, that obviously that's a different condition. And the presence of diarrhea is another possibility that can be presented with that. So those are the things that we define as clinical presentation. What about the epidemiology? How common this is? Well, if you go to the literature, you know, there are patients who have conditions like diabetes. Diabetes, gastroparesis is fairly common, between 30 and 50% can have that presentation. And gastroparesis in general is more common in females than in males. The contrast between adult gastroparesis and pediatric gastroparesis can resolve, you know, with time, especially in those conditions that are associated with a virus. I will say the number one reason for gastroparesis, as you know, is we don't know, is idiopathic. But in the pediatric population, you get a post-viral gastroparesis, can be present people who has, for instance, mononucleosis, rotavirus, coronavirus can produce that. And if you have a CMV infection or varicella can produce that. So I think post infection is a common thing that we see. And again, it has the prognosis that improve. Could be associated with other reasons like medications, drugs, also can be associated. Even sometimes PPIs, proton pump inhibitors for the management of reflux can produce as well this type of a situation. And if you look at the natural history of gastroparesis in quoting an adult paper, this is important to remember. And the gastroparesis in children in the publication done by our group and Dr. Rodriguez, there were 242 patients with pediatric with gastroparesis. The mean age was 9 years, and 18% had post-viral gastroparesis, 8% had metabolic situation. Express one of the most common reasons to have that is mitochondrial disorders like that. 22% of resolution of the symptoms after 6 months, 53% in 18 months, and 60% after 36%. Of course, that is the good news. The bad news that there, if you see there in that percentage of patients, half of them, a third of them, they might still have recurrence of the problems, you know. And the factors that they are not positive for patients with gastroparesis is, number one, the younger the child is, the worse the prognosis is. If there is a male, also is not a great thing to have. Shorter duration of the symptoms and the lack of response to prokinetic agents is another reason to cause that, you know. So I think that is important to remember too. In severe patients with severe gastroparesis that require the more aggressive type of support, those patients tend to do worse than that. So I'm going to stop there and see if we can interact about in terms of the definition. If you have questions, Maryangela, about the definition and how we see in the pediatric world patients with gastroparesis.
Yes, definitely. And so one question would be, what is the age range when you begin to see patients that show clinical presentation of gastroparesis?
Well, it's an interesting question, because we can see it in preemies. The premature babies, for instance, they don't have the whole apparatus well developed, you know, and the mesenteric plexus is not quite the thing for me. So that is always a concern from in terms of what happened with these children, you know. So I don't say that it's an age. It's very prominent, for instance, in patients in adolescents sometimes, you know, they can have that, or patients that have had multiple interventions, congenital cardiac anomalies, abdominal surgery, malrotation of the intestine. So I don't think it's an age, but in the series that reported from our institutions, the middle age was 8-9 years of age, but I wouldn't limit that, you know, they can present in any age, basically.
And are you finding more patients with that?
Well, gastroparesis in the pediatric population, I think that we don't have a lot of solid data of the epidemiology, but I would say, I think the prevalence is 30%, you know, maybe 10 cases per 100,000 that we see. The most common reason for pediatric motility in patients with gastroparesis is in motility disorders. Number one is refractory constipation. Number two is gastroparesis. So I think we see a lot of that present. Yeah.
I see. So how do you go about making that differential diagnosis?
Well, one of the things I think is important to remember is the pathophysiology. And I'm not going to go too much in detail, but I think Dr. McCallum showed a picture of the stomach. You know how the stomach has two chambers. And you still see me or no?
Yes, we can see you.
Okay. So one of the pathophysiological events that can be associated with gastroparesis, including the condition called tonic funding contractions. They are decreased also contraction of the antrum. The stomach has two segments. One is the antrum and one is the fundus. The fundus of the stomach, in top of the stomach, that is associated with storage of gas and fluid. And that can be obviously abnormal in patients with gastroparesis. And also the other thing that might be something to think about it is the antrum of the stomach, which is the pump of the stomach, also might be abnormal as well. So that's another factor. And then we have the inhibitory forces of the pylorus and the duodenal contraction. And there is another element that is always to remember is the vagal nerve that controls the mechanics of the stomach via nitrous oxide or CCK mediation, which is two hormones. And so the funding pacemaker is another issue that we have there, and recurrent this interaction between the muscle and the sensory activity of the myenteric plexus. So there are different things that cause that. Now, how do we make the diagnosis of the implications of this? Well, I think there's some relationship with symptoms. If you have delayed gastric emptying, you will have vomiting and postprandial fullness. If you have delayed proximal gastric emptying, you have heartburn and regurgitation. If you have impaired accommodation of the stomach, that means that the food comes, the first part that hits the stomach is the fundus, and that will produce early satiety, pain, and belching. The belching is important because we know now that there is a condition called the supragastric belching syndrome, that is people will belch constantly and might be associated with inability to expel the gas. The very interesting thing is there can be gastric dysrhythmias associated with gastroparesis, and that reduces abdominal pain and also nausea, probably associated with that. Another element of that, which is abnormal, is especially in patients with gastroparesis. So in brief, you have abnormal vagal neuropathies that can affect the nerves. You have the defective nitrous oxide pathways, and that can develop in hyperglycemia. The data in pediatrics associated with diabetes, for instance, is all back almost 30 years ago. And those patients were found to have inability to empty the stomach appropriately, what we call postprandial antral hypomotility. So I think those are the main symptoms that makes you think about it, and then you go for the etiology of the problems. If you want, we can talk a little bit more about that specific conditions that can cause that in the pediatric population. But those are the sort of how this work in terms of abnormalities in the physiology. Yeah.
So what kind of testing is done in the pediatric population in order to find if it is gastroparesis?
Well, what I'm gonna do, Maryangela, is maybe go a little bit of the etiology, talk about some conditions, that are associated with this.
Sure, absolutely.
So there could be mechanical problems, right? If you have an ulcer in the duodenum or a gastric ulcer, that can produce gastroparesis, And one of the things that can cause that is a patient with Helicobacter pylori. As you know, that is one of the most common, if not the most common infection in the stomach. And those patients can have abnormalities in that. And that's important to think as an etiology. Patients who have had operations, like fundoplication. We don't do so many of those. Fundoplication is when you fold the top of the stomach to avoid gastroesophageal reflux. Patients with bariatric surgery, placement of PEGs, which is done percutaneous endoscopic gastrostomy. Those patients, inadvertently, the pacemakers can be damaged, and they develop also gastroparesis. Patient who has gastric operation, gastrectomies, patients who have had heart lung transplantation, and the late appearance of pyloric stenosis. Non-mechanical things, we talk about diabetes, hypothyroidism, hyperthyroidism, renal failure can produce that. Patients with celiac disease can be also affected with emptying of the stomach. Inflammatory bowel disease, Crohn's can present like that. Obviously, all the demyelinating neuropathies, myotonic dystrophy, etc., they can produce that. And then obviously connective tissue problems, that is scleroderma or the connective tissue disorders as well. Then there is conditions like Dr. McCallum talked in the past, patients with POTS syndrome or patients with Ehlers-Danlos, or all the hypermobility, autonomic nervous system dysfunction. So we see that commonly in the pediatric population. Patients who had chemotherapy for malignancies, they can be also damage of the mesenteric plexus, ischemia. And one common thing in premise is the presence of necrotizing enterocolitis. And those patients tend to have problems with this motility and delayed gastric emptying. And of course, there are medications that can produce that, anticholinergic, tricyclics antidepressant, calcium channel blockers can affect that. So, but again, one of the main things that we see is the post-viral gastroparesis, and that was the initial paper we reported in 1997. So that is in terms of etiology. Now, diagnosis. Obviously, you still need to talk to the patient. That's important. One of the things that now with the change of way that we see patients, even telemedicine, I think it's important to get a detailed history and timing of symptoms. Obviously, if you want to examine the patient, if they have a succussion splash, distension at time of related to meals, usually we ask the parents to take a morning and PM picture and measure the abdominal girth. And then if the patient has a long-standing gastroparesis, they will have failure to thrive, period. That's important to think about it and ask the parents about it. Now, there is a condition that presents in adolescents that I think you have to have present because it comes in the differential diagnosis. It will call food regurgitation or reswallowing syndrome, and also called a rumination. And that is a different condition that you make the diagnosis clinically by history, or you make a diagnosis doing an esophageal motility or intraduodenal motility. So those are the main clinical diagnosis by symptoms that we have. And I think obviously the babies don't talk to you and all that, but you get the idea where we're going. So specific things that you obtain for the diagnosis. Let me stop there and see if there are any questions or anything in terms of the etiology of the gastroparesis. Any specific questions?
Let me just check the Q&A and see. Somebody wrote, her daughter is 37, diagnosed with AML, 114/20. Chemo stopped her heart twice, ICU 50 days, surgery 12/22/20 for bowel obstruction, surgery to take out 12.9 centimeters of intestines and surgery, nausea every day, had TPN, can't eat, and G-tube for months, now PEG tube in April and ESRF. She has lost 30 pounds since November, back and forth in hospitals with bacterial and fungal infections. Now she's vomiting all the time. GI docs really haven't addressed anything with her. I want gastroparesis to be checked. Is this good to ask?
Absolutely. I mean, that patient has a lot of red flags there, you know, because this patient had the chemotherapy, had the malignancy. So as I explained, to one of the reasons to happen is because there is sometimes low perfusional states and the myenteric plexus very fine mechanism. So yeah, that patient needs to be evaluated for gastroparesis. So perhaps it's a good time now to talk about what are the specific diagnostic tools that we have for that. You can get a flat plate of the abdomen and you can see dilated stomach, and it's important to do that. One of the common things that people don't think about is refractory constipation. Refractory constipation is tied sometimes with gastroparesis because the gastrocolonic reflex is sometimes disappears in patients with refractory constipation. That's the positive feedback when you eat. A lot of people wakes up in the morning, they have a nice cup of coffee, they hit the toilet, very happy, tutti contenti for the rest of the day, right? But that doesn't happen to everybody. Then going in the list, you have the upper GI and small intestinal series, be sure that there is no anatomical problems, that the intestine is not malrotated. And some places in Europe, for instance, they're very good doing gastric empties with abdominal ultrasound. We don't do that too much in the United States. Radio opaque markers, the poor people gastric emptying studies. Then you can do a stable isotope red test to diagnose that. Intraduodenal manometry is important in some patients with gastroparesis. We can talk about that as well. Electrogastrography, the smart pill. The smart pill is a pill that you swallow and that you can measure the motility of the stomach. A CT scan is used experimentally so much, MRI as well, and then the water loading test. But the gold standard really is the gastric emptying study. Basically, you tie food with magnesium, and the validated timing is 4 hours. In 4 hours, you have more than 10%. I will say that's universal. I think data from Dr. McCallum again and Dr. Park, they've been thinking that may modify that. But I would say in clinical practice, if you have a gastric empty, that you don't empty less than 10% in 4 hours, that is abnormal. And this has been validated now in pediatrics. We wrote a paper back in November of last year in which retrospective analysis of 1,000 patients who had solid phase gastric empty scintigraphy. And the bottom line of that paper, pediatric solid gastric empty scintigraphy, is that the adult normative standards for gastric emptying are applicable to in the pediatric population, which is good news, because we can do that. Then is another test that is still that it might be helpful is the smart pill. Basically, you swallow this pill that measures pH, pressure, and temperature, and the moment the pill leaves the stomach, you can ascertain that there and measure the gastric emptying. I think this is the wireless motility capsule, and in pediatrics it's been studied very well by the group of Dr. Di Lorenzo in Columbus. So in summary, the pros and cons of current diagnostic methods. We have scintigraphy. It gives you a little bit of radiation, but not enough to be concerned. And it's important to do it. I think intraduodenal manometry is more elaborated. You have to place a catheter, and it's a little bothersome unless you have a gastroscopy. You can put in the gastroscopy. Electrocardiography, gastrography, not available in our place, and the same thing for a smart pill. So I think I will say in 2021, depending on the center, for instance, we tend to favor gastric empties here in our institution. I know that some other places do breath testing, but we don't do that here. So I think in terms of diagnosis, I think that's where we go there in terms of how do you do that. So that is in terms of what do we use now for us. So you can do the smart pill, you can do the electrogastrography, again, not in a clinical practice, at least in our institution, and we stay with the gastric emptying study. We can do liquid, especially for infants or toddlers that they don't need, for patients with neurologically challenged cerebral palsy seizure disorder, those patients, we do liquid gastric emptying. The standard for our lab here, we have, if you do more than 50% retention after 1 hour, we consider that is delay. So I think I'm going to stop there in terms of diagnosis of this condition.
So, Dr. Flores, patients want that hope. What type of research is being done for pediatric gastroparesis?
Well, the main research right now is in terms of new drugs, that can help us with the gastroparesis. And there is a couple of things I can talk to that about when we talk about medicine, in terms of the therapy. How long we have more, Maryangela?
We have about 3 minutes.
3 minutes.
So 2 minutes. 2 minutes.
2 minutes. So I will say, in terms of management, there is drug management with antiemetics, different types, aprepitant, scopolamine, ondansetron, ganisentron, pain control with antibiotics. And then there is 2 things that we have to think about is the gastric electrical stimulation and the use of intra-pyloric Botox injection. And that is and new drugs, like the type of drugs that might improve, like tradipitant is another drug for that. And perhaps we cannot ignore the use of the G-POEM, which is gastric peroral endoscopic pyloromyotomy in treatment of gastroparesis. We can talk a little bit more if we have chance. So there is some active research done in terms of that. The new surgical intervention is the G-POEM, as I said, the peroral endoscopic pyloromyotomy for the treatment of gastroparesis. So I'm going to stop there.
Okay. Can I just ask you one quick question?
Yes.
With all of these symptoms and with all of the tests that go on, and then finally you have the patient, are your patients well managed, or do they go on through adulthood or transitioning to teens and still have those same struggles?
I think that depends on the luck of the draw, and where are you located and what is the facilities that they have that. I unfortunately still see a lot of patients that they've been managed poorly in terms of making the diagnosis of the intervention. So I will say it's unfortunate, but it's still not an ideal management. Even by general gastroenterologists, they still not able to do that. And there's few places that really do the motility. But I think it's better than it was 20 years ago, obviously, because the literature and the electronic life is make it easy. But we still see patients that they don't they make the right diagnosis and then not the right therapeutic approach. Yeah.
I see. Well, Dr. Flores, we can't thank you enough for being here today and answering these questions and all your explanations.